Hello, and welcome to the Bourne Hall webinar. It's a game of two halves, tackling male infertility. Thank you so much for attending this evening. We've got two guests for you tonight. Oliver Wiseman is a consultant urologist and andrologist. Urology is the study of urinary tract and male reproductive organs, and Oliver is one of only a few urologists in the country to specialise in fertility medicine. So we are delighted to have him as a male fertility consultant at Bourne Hall. We also have a Bourne Hall patient, Matt O'Malley. Matt had successful treatment at Bourne Hall and now has a little girl, Elle. He admits that it came as a complete shock to be told there was an issue with his sperm and devastated when the couple had 2 miscarriages. We're very grateful that he's agreed to share his journey with us tonight. I'm Rachel Holdsworth, Head of Communications at Bourne Hall, and I'll be facilitating this webinar. The plan is that we'll watch 2 short video interviews with our guests and then open up for a discussion. We've muted your mics and videos so no one can hear or see you, and this is to ensure that we can keep the focus on our speakers. If you'd like to ask a question, then please use the Q&A function, and we'll try and include as many as possible in the discussion. We've also posted a poll so we can get an idea of who we're speaking to, so please answer it now or whilst you're watching the videos, and we'll close the poll when the video finishes. The videos and a recording of this webinar will be available afterwards on the Bourne Hall website. So first up, we have a video interview with Matt talking about his experiences. That will be followed by Oliver, who will explain what the semen analysis reveals, how to improve poor sperm quality, and the treatment options that are available.
So, hi, my name's Matt, married to Laura with a daughter, Elle, born last April, who's now coming up for 18 months, born after successful treatment at Bourne Hall using ICSI. Myself and Laura have been trying for about a year before we sought medical help, a bit of a health MOT. Laura initially went to the GP for a sort of a checkup and just to make sure everything was okay. They ruled her out as having any issues or complications. About 3 months later, I was referred by the GP to go to a fertility testing clinic. The test revealed that my motility, whilst my count was high, my motility was very low. And it was a bit of a shock to the system to find that the issue was with me. Not that I'd ever wanted to be with Laura, but I think as a male, you just automatically assume you can have children. It's a given, but in this case, it wasn't. I think once we found out the results and IVF was definitely a route that we were going to have to take, we both felt relief, and because we saw a path, and we're both very, as long as we can see where we're going, we're fine and we're quite clear. So we felt it was a win because you just feel that, okay, we're going to get the professionals involved now. We're going to get it sorted, and we're going to get it because we both ultimately wanted a child. At the end of the day, that's all we wanted. And how we got there, it didn't matter. So once we arrived at Bourne Hall, we were advised that ICSI was the best solution just due to the motility, where they take the one sperm and inject it straight into the egg. The option was there for the sort of standard IVF, but because of my motility, ICSI was the recommended route to go. We had 3 attempts for ICSI, and unfortunately the first 2 resulted in miscarriages. After suffering 2 miscarriages, I changed as people close to me had seen that I changed, and my relationship started to suffer because of this. But it was hard to describe. I was very withdrawn. I was very changed, and it's something that I've really grown to understand, that I should have been speaking to people after the first miscarriage, because naturally people will always ask after the woman when a miscarriage happens, and no one asks after the bloke. So I really struggled with that, and I don't like talking about my feelings. I'm a typical male. I don't like talking about them, but I did look to go to counselling, and then stupidly decided it wasn't for me. And it was only when I'd started talking a bit more openly about male infertility and sort of our experience that it sort of gave me a kick and realised that I should have been doing it a long time ago. There's nothing to be ashamed of. There's nothing to hide. It's part of who you are, effectively. So when Laura actually when the embryo was transferred into Laura, And after 10 weeks, we got a positive pregnancy result. It was amazing. It was a step that we'd reached twice before, but we just had a really good feeling about this one. It was a feeling that we've not had before. I don't think the sense of sort of holding your breath goes away until week 40, but it was it was the best feeling in the world to know that, you know, we have created life effectively. Granted, with a little bit of science, but it's life still the same. So when Elle was born, it was the best feeling in the world. It felt like those years of emotional turmoil, physical turmoil as well for Laura, had all been worth it. And yeah, wouldn't change anything for the world, because we've got a belter. So now that I'm a dad, I would definitely recommend talking. I think it's sort of society dictates that we're not allowed to share our feelings and get off our chest what is really bugging us. And at the end of the day, it's not a failure, it's not a deficiency. It's sometimes it's physically just how you're built, and there's nothing to be ashamed of that. I found that it crept up on me. As I say, I wasn't snappy or short, but my personality changed. I just become a lot more withdrawn. And I think seeing those signs now in other people, it's definitely important that they communicate that, because at the end of the day, there is options out there. It will get better.
I'm Oliver Wiseman. I'm a consultant andrologist, and I specialise in the treatment of male fertility problems at Bourne Hall. So overall, there's a male-only factor in about 30% of infertile couples. In another 20%, there's a male factor as well as a female factor. So in 50% of couples, there's a significant male factor contributing to the fertility problems. Sperm is produced within the testicles. The testicles have only got two jobs. One is to make sperm, and the second is to make the male hormone testosterone. And unlike in the female, where all of the eggs are present at birth, in men, sperm are produced continuously. And so even a relatively short period of illness in a man can affect the sperm count subsequently for up to 3 months. When we look at a semen analysis, there are a number of factors which we're looking for. The first is what's the total volume of the ejaculate? And the second is what the acidity of the ejaculate is, because variations in the volume and variations in the pH or the acidity of the ejaculate can help to tell exactly what might be the problem behind the low sperm count. As well as looking at those, though, we're also looking at the overall sperm count. So how many millions of sperm are there per milliliter of ejaculate? Also, how well those sperm are moving, how many sperm should look normal. And those are the things which give us an idea of the healthiness of the sperm. So from the point of view of causes of poor sperm count, there can be medical problems which the male is suffering from. They can be problems with production of hormones, which can affect the testicles' ability to make sperm. But more commonly, there can be a structural abnormality actually within the scrotum. And one of the commonest things which we would see is a big dilated bag of veins around the testicle, and can be present in up to 40% of men who have fertility problems. And that's called a varicocele. We know that repair of the varicocele can then lead to an improvement in the sperm count. If we find no sperm in the ejaculate, then what we need to do is try and work out whether the problem is one of there being a blockage, such as, for instance, a man who's had a vasectomy before, or a patient who has cystic fibrosis, or whether the problem is a problem of production and a non-obstructive azoospermia. They may have had a history of, for instance, undescended testicles of a child, or of a torsion or a twist of the testicle. Or maybe they will have had some cancer treatment, chemotherapy, or something like that. And then also lifestyle factors can affect the sperm count. One of the commonest things which we see now is patients who have a high BMI, and that can significantly affect the sperm count. Because what happens is sperm need high levels of testosterone, which is the hormone that's produced within the testicle, and that helps to support sperm manufacture. And that testosterone can be converted by fatty tissue into the female hormone estrogen. And so not only are the testosterone counts then lower in men who have obesity, but also the estrogen levels are higher, and sperm don't do well with higher estrogen levels. But other factors which are important to consider are also healthy eating, so trying to avoid processed foods, takeaway foods, and trying to have more fruit and vegetables, avoiding saunas and hot baths, which have the effect of heating up the testicles and which can also affect sperm production. Moderate exercise is important. So for moderate, we're talking about half an hour to an hour, maybe 3 or 4 times a week. I'm not talking about 4 or 5 hours on a bicycle, which probably wouldn't be good. So there are a wide range of things which men can do to try and improve their sperm count themselves, but it's also important that they are assessed if they have a low sperm count by a specialist to make sure there's nothing more serious and nothing operatively, so surgically, that we could do to improve the sperm count. So making sure that all of those reversible factors are optimized, I think, is really important before going down the route of IVF. Because even if it doesn't improve the sperm count to a level whereby the couple can conceive naturally, it's likely to lead to better quality of sperm, which can then be used for IVF and is more likely to make the IVF successful.
So thank you very much for those two videos. They were brilliant. So if you'd like to just unmute yourselves and so we can actually see you, that would be brilliant. And Matt, yeah, are you there? Yep, Matt's there as well. So that's brilliant. Okay, so just coming to you, Oliver, first. I understand that it's quite unusual for a urologist to specialise in male infertility. What was it that got you into fertility medicine?
Good evening, Rachel. I just want to say, having watched that video back, I'm going to have to really focus on speaking really, really slowly, because it looked like I was turned up to about 1.5 times my normal speed there. So my interest in fertility actually really came when I came to Bourne Hall and had a look around the clinic and had a look around particularly the embryology laboratory. So I decided that I was going to offer vasectomy reversals to patients. And as part of that service, I wanted to be able to offer men the opportunity to freeze some sperm at the time of the procedure. So if the procedure wasn't successful, then they would be able to use that sperm through IVF. And I came to speak to the clinic, and I had a tour of the laboratory, and I just found the whole place so inspirational that I then, and this was 12 years ago, went off and did some more training in andrology, which is the study of male fertility, amongst other things, so that I could then offer that service to patients.
Yes, that's great. And you must see men daily that have been told that there's an issue with their sperm, and they probably, from what Matt's saying, is quite a shock. So what sort of reactions do they have to the news, and what sort of things do you say to them at that very early stage?
Well, I think it's complete surprise, really, a bit like Matt was saying, because there's so much focus in infertility on the female partner. And indeed, the whole way that most referrals are still structured for patients who have fertility problems is around the female partner, with them going often to the female partner's GP and then being referred to a female reproductive medicine specialist. That, I don't think that most men think that it's going to be a problem with their sperm count. But as you saw from the video, it can be an up to 50% a contributory factor. The first thing for me to say is that even in men where there is no sperm in the ejaculate, nothing at all, there are still things that we can do to try and find sperm which can then be used for treatment. And in men where the sperm quality or quantity is low, there are things that we can do, such as those things I was talking about, lifestyle factors, and also some surgically correctable or operations that we can do to improve things, so that the couple can sometimes also conceive naturally. So there are many things that can be done, and I would say that they should, seek a specialist opinion, and just be sure that they haven't left any stone unturned in trying to improve their own fertility.
Yes, that's good advice. And from our little poll here that we've done, 80% of people say that they haven't seen an andrologist or a male fertility specialist. And just to give you a feeling of the people that are listening, about 12% are just at the first stage concerned about their fertility. About just over 50% have had results from a semen analysis. So they're sort of level 2, they've just had their testing. And then about 30% are in treatment. So that gives you a feeling about where people are on their journey. Yes. So Matt, I'll just come to you. Thank you very much. It was a very moving interview, and very grateful you've shared it with us. It's often very difficult to get men to talk about their experiences. So, it's special that you're here. If you're thinking back on your journey, do you think now that it would have been more helpful to you if you'd been more open earlier in your journey about your feelings?
Yeah, I still remember when I got the results back, and the sort of the feeling of this can't be right. It was that denial at the first sort of step, and as I say, it was a sort of a long burn to sort of, as we went through the different cycles, the sort of the different so yeah, cycles is probably the right word. That I started to get to feel I never want to feel like I'm the blocker, and I didn't talk to anyone. It was only really after the second miscarriages, that's probably when I started to talk to close friends. I went on a trip around Europe. We did a driving trip, and I sort of always say this, that's when I really, my friends that I was with could see that I didn't want to be there. I just had no enthusiasm because I was just sort of mentally drained after 2 or 3 years of backwards and forwards. And it was only when I sort of after that trip that I started to speak about it to my close friends that things started to get a bit easier and the weight started to get a bit lifted. And yeah, you know, I think it's important that to start, there's nothing to be ashamed or embarrassed about. It is part and parcel, like I said in the video.
Yes. And is there anything that you'd wish you'd known at the start? You know, were you investigated for your fertility right at the beginning, or did they concentrate on Laura first?
It was concentrated on Laura first. And not I was an afterthought, but yeah, it was Laura was the focus first of all. She's had irregular cycles previously, so they wanted to rule out everything. So I was the last option to be like, oh, okay, Laura's fine, and then you kind of feel like that pressure on you, like, oh god, and you never, you never want it to be the other person because you love that person as your partner. Equally, you don't want to be the one in the spotlight. But yeah, it was focused on Laura first of all.
Yeah, right. And Oliver, and one of the things that comes out in your interview is that the sperm counts and sperm quality change. And that might be quite sort of enlightening for some people listening to tonight. What are the important things that you can do for yourself to actually improve the sperm quality?
So I mean, you mentioned, Rachel, that the sperm quality changes. I think the first thing to say is that you should always have 2 semen analyses or sperm tests done at least 3 months apart. Because as I said, sperm are produced continuously. And so if a man is unwell with a febrile illness or you know, some other medical problem, then that can actually affect the sperm count for that sperm cycle, if you like, and it takes 3 months to make sperm. So I wouldn't necessarily assume that just because an initial sperm count is bad, that a second one maybe 3 months later would be. So always have 2 sperm counts done at least 3 months apart, and make sure that the instructions for completing the sperm count are undertaken, and that's normally an abstinence of between 2 and 5 days. So just to get the basics right, so that you can start off with, you know, the correct diagnosis. To try and improve the sperm count, though, over time, I mean, you know, there are some obvious health and lifestyle factors which I touched on in the video, but which are fairly straightforward. So, you know, there are men who smoke, and smoking can have a really bad effect on the sperm count and the sperm quality. The next most common thing I would say that maybe isn't so easy to change is the BMI. And you know, we are as a nation growing bigger, and BMI is increasing, and that's a harder thing for a lot of men to change. But I think for some of them, when I explain to them the reasons why, they then do actually go away and are able to lose some weight with that extra motivation, if you like. And you know, long term, the additional health benefits to them are also significant.
One of the things you mentioned was that the problem with BMI is that men are converting testosterone into the female hormone.
That's right.
Estrogen, which is sort of quite, lots of people probably won't realise that. Can you just explain that a bit more?
Yeah, so within fatty tissue, there's actually an enzyme which we all have, and which women have as well, which converts the male hormone, testosterone, which is made in the testicles, and it converts it to estrogen. And where sperm are developed in the testicles, they like to have really high levels of testosterone in the environment where the sperm are being made. Obviously, that's important, but also estrogen levels, when they are high, they are very bad. They have a very bad effect on sperm development. So having a high BMI, apart from all the other health issues which they can bring on, such as diabetes, which can affect sperm quality and those sorts of things, they also will have an effect on sperm production within the testicle. So weight loss can really be something that's quite important.
Yes. And just when someone comes to treatment, is it important for the man to have a BMI of a certain level? I know that women you won't treat if they've got a BMI over about 30.
Yeah, I mean, the actual guidelines differ according to which CCG or which group of GPs are being, the patient is being referred from. But ideally, we would like to see a man whose BMI is less than 30 as well. And
Yes.
certainly it affects what treatments we can also give them at Bourne Hall. If we need to, let's say, do an operation on them to try and find sperm, then that operation itself is also a little bit riskier from the anesthetic point of view if the BMI is high.
Yes. And one of the things that Matt was talking about was the morphology, the shape of the sperm, and also motility, the speed that they're going out is important. I mean, can the changes that you're talking about, can they impact those factors as well?
Oh yeah, absolutely. So we would see smoking, BMI, recreational drug use as well. All of those factors can affect the three main things that we look at in the sperm count. So one is the concentration of the sperm. So how many sperm are there per milliliter of ejaculate? The second thing that we look at, which is what Matt was talking about, is the motility. So how well those sperm are moving. And then finally, it's the morphology, and that's what the sperm look like under the microscope. Do they look normal or not? Rather unbelievably, you only need to have 4% of sperm looking normal for it to be called a normal sperm count.
Yes,
so, the human race isn't great at making normal looking sperm, I think, is the bottom line.
Right, okay. And then sort of other things, a question that people might have that they might not want to ask is, what about having sex? Is it better to have sex more often or less often if you've got a low sperm count?
So the time around ovulation is key. And certainly having it every day or 2 days, starting a couple of days before ovulation, is what most people would recommend.
Yes.
The analysis which is done, so the semen analysis that we use to tell whether the sperm count is normal or not, is always done with an abstinence between 2 and 5 days. But often the if sperm production is normal, then the quality and the quantity of the sperm that's produced after another day will absolutely be sufficient for fertilization.
And then other factors, I mean, is anxiety, I mean, a lot of people have stressful jobs. I mean, can that affect your sperm count as well?
So stress is a massive issue, and stress is a massive issue because it raises a man's production of steroids or of cortisol, which is a hormone, and that's a normal response to stress. And that can absolutely affect both the libido, and it can also affect a man's sperm count. I mentioned steroids, and it's also just worth talking a little bit maybe about steroid use and abuse. So some men have steroids because for a medical condition they need to have it, but other patients or men will go to the gym, for instance, a bodybuilder, and they will sometimes be given some products to use, tablets, injections, shakes, those sorts of things. And often they aren't always sure what's in those.
Yes.
And they may well contain products that can affect sperm manufacture. And sometimes those are steroid-based products. So I would always advise men who are considering fertility really to try and avoid any of those sorts of products.
Yeah, that's good advice. And Matt, with yourself, I mean, there's quite a lot of things that people say which might not have much weight in them, but did you read around about male infertility? Were there anything, particular things that you tried to improve your health?
Yeah, so both myself and Laura have been relatively healthy, but I think there's always room for improvement in any walk of life. I think once we got my results back, we cut takeaways out, and we're having probably 2 or 3 takeaways a month. It wasn't, but I stopped drinking for about 2.5 years. I haven't had a drink since, and that's just something I've carried on. But I was only drinking once a month, going out to the pub with a couple of mates. It was nothing heavy, but we removed every barrier that potentially could to do anything, just to be on the safe side. Everything was cooked from home. We stopped anything that potentially we didn't know or couldn't read where the ingredients were coming from. But like Oliver was saying, even down to medicines, vitamins, if we couldn't identify what the product was, we weren't taking it. We were being so cautious just to try and give us every chance to make it happen. Because whilst we were going through treatment, we were still trying to conceive naturally, even though we know that it was a incredibly long shot.
Yes, yeah. That's great. Now, Oliver, you've talked about lifestyle changes, but also you mentioned on your video that there was some surgical treatments you could do. And one of the things you mentioned was that 40% of men have with fertility issues have a varicocele.
Yes.
That can be treated. Would you mind just explaining that again a bit more?
No, sure. So a varicocele is a dilatation of the veins around the testicle. A little bit like you see varicose veins in the leg, you can get that around the testicle as well. And it's much, much commoner on the left side than the right side, just because of the anatomy. Now, the testicles lie outside of the body for a reason, and that's because it's a couple of degrees cooler outside of the body. And that's the optimal temperature for sperm manufacture. If the testicles are surrounded by these big dilated veins, then what can happen is that heats up the testicle, and it means that it's not an optimal environment for the manufacture of sperm. And so that can affect the sperm concentration that we talked about. It can affect also the sperm motility, how well they're moving, and also what percentage look normal. But as well as that, we haven't talked about, it can also affect the sperm DNA fragmentation, which is not something that we usually look at when we're assessing the quality of the sperm, but it's really, what's the DNA of the sperm look like. So if a man feels, it's described typically like a bag of worms, or you can feel these big kind of squishy worms within the scrotal sac on the left-hand side normally. If a man feels that and the sperm count is low, then often treating that will improve the sperm parameters, and it can also then lead to an increased rate of pregnancy.
Yes.
Spontaneously.
That's spontaneous. That's what I was going to ask.
Exactly.
Yes. Yeah.
But I also talk in the video about the importance of improving the sperm parameters, so that a little bit like for Matt, you're going to have the best quality sperm that you can have by improving all the lifestyle factors, and then also improving things like a varicocele before you use any sperm for IVF. So you give yourselves the best chance of that treatment being successful.
Yeah, that's good. And talking about IVF, I mean, Matt gave quite a good explanation of it, that it's harvesting the eggs and then mixing the eggs with the sperm. But are there any special things that happen if you've got male fertility problems?
Well, I think Matt mentioned that, correct me if I'm wrong, Matt, that you and Laura had ICSI as well. Is that right?
Correct. Yeah.
So ICSI has completely revolutionized or changed the way that male factor infertility is treated. Because now with ICSI involves just being able to find an individual sperm and injecting that individual sperm into an egg. And that was a step change, because it means that you can really work with really low numbers of sperm in order to achieve a successful outcome from IVF. And before that, what used to happen was that the eggs and the sperm just used to be mixed together, and then you'd kind of let nature do its own thing and see which sperm would fertilize an egg. But really with ICSI, because the sperm numbers often in a male factor couple are so low, you're kind of bypassing that and you're injecting the individual sperm into the individual eggs. So ICSI is a step change. It's revolutionized the whole treatment of a couple where there's a male factor, and led to much greater success rates.
Yes, yeah, it's a real breakthrough, isn't it?
Yeah.
Yes. You know, you were talking that actually even in healthy sperm, in semen, there's very few healthy sperm. But what happens if there's no sperm at all in the ejaculate? Can you still find sperm from somewhere?
Yeah, so in the video, I talked about the two possible reasons why there might be no sperm. One is that there's a problem with production of sperm. So the testicles aren't working normally, and very low numbers or no sperm are being produced, or they're being produced in such low numbers that they don't survive to get into the ejaculate. So that's a condition that's called non-obstructive, which means there's no blockage, azoospermia. And azoospermia means there are no sperm present in the ejaculate. So that's the first type of azoospermia, or no sperm present, is because of a problem with production. The second type is obstructive azoospermia, where the testicles are working normally, but for whatever reason, the sperm can't make it into the ejaculate. And that is a situation where you can almost always get sperm directly from the testicle or from the epididymis, but it takes a small procedure to do that. And the two procedures that we can do that with are either a procedure called PESA, that's PESA, which is where we pass a small needle into the epididymis, which is a very fine tube that leads from the testicle into the vas tube, and we try and suck some sperm out from that. Or we make a small cut in the middle of the scrotum, and we take out a little piece of testicular tissue, and that's a procedure called TZ, or testicular sperm extraction. So we will almost always find sperm in patients where there's a blockage, and where production of sperm is normal.
Yes.
Where there's a problem with production, where you've got non-obstructive azoospermia, in about 50% of those patients, there are still small areas within the testicle where sperm might be being made. So we do a much more extensive operation to try and look for sperm, which is a procedure called microsurgical testicular sperm extraction, where we actually, under an anesthetic, we open up the testicle and we have a look at the architecture of the testicle, and we select those areas which appear to be the best looking, if you like, to remove the tubules from, and we give those to the embryologist to see if they can find sperm within those tubules. And that's got, as I say, about a 50% chance of finding sperm. So even where the FSH is really, really high, that's a hormone that we use to try and work out what the problem might be with sperm production. Even when FSH is really, really high in men with azoospermia, we can still find sperm in about 50% of people that can then be used for IVF and ICSI.
So if you're deciding whether or not you need to go into one of those more invasive types of surgical sperm retrieval, what sort of tests would you do in addition to that sort of initial semen analysis?
So the next thing that we need to do are those hormone tests that I've already alluded to. So one is a check of the FSH, which is a hormone that is produced by a small little gland in the brain that sends signals down to the testicle, telling the testicle to make sperm. So if the FSH is very high, that suggests there's a problem with sperm production. If the FSH is normal, it suggests, not always, but it suggests that the testicles are making sperm normally. So one hormone test is FSH, and the second hormone test also is testosterone, because as I said, you need to have good levels of testosterone being made in the testicle to support the manufacture of sperm. So normally with those two hormone tests, and then an examination and a history from a male fertility specialist, we can normally explain and give an indication of whether we think the problem is one of a blockage, so obstructive azoospermia, or whether the problem is one of a problem with production, which is non-obstructive azoospermia.
Yes. And how long do those tests normally take? I mean, perhaps Matt, you can just tell us, when after you first went to your GP and then started having your tests, how long did that process take when you were having your tests?
Oh, the test itself was quite straightforward and quick. I think from memory, it was about 2 weeks for the results to be returned. Oliver might be able to confirm that, but I think it was about 2 weeks when we had the first set of results back.
Yeah, I think that's normally about right, Matt, for a semen analysis. By the time it's got to the lab, it's been reported, and the report has got back to your GP or otherwise. Yeah. And then I don't know if you had any blood tests, Matt, at all, but I suspect that if your sperm count was pretty good and it was just the motility that wasn't good, you may not have done. But normally those blood tests come back within a day. I mean, it may take a day or two longer to get the results from the GP, but normally it's a test that most laboratories would run each day.
Yeah. We had bloods on each cycle. I had bloods for standard, I think more screening for things, just to make sure everything was fine. But yeah.
Yeah, no, that's great. And then you were just talking about surgical sperm retrieval, which is sort of an exceptional. And then after, it sounded quite invasive. I mean, is it a sort of an outpatient's operation that, and how long would it take you to recover after you've had a surgical sperm retrieval?
So if it depends on which retrieval you need to have, really. So if it's the kind of retrieval where the testes are working normally, and we think there are sperm within the testicle, and we just manage to get some sperm out with a needle, it's normally 2 or 3 days off work, and there's a bit of bruising, and there's no cut at all. There's an option to have that with local anaesthetic or general anaesthetic, and we do that at the Bourne Hall Clinic in Cambridge, but you're in and out on the same day for that kind of procedure. All of the sperm retrieval operations we do, you are in and out on the same day. So there's no overnight stay. And then the other two, so where we need to take a small little piece of testicular tissue, you probably need 10 days off work for that, 7 to 10 days, depending upon what kind of work that you do. And that operation itself takes about half an hour. But the more extensive operation, where there's a problem with production of sperm or a microteasy, I would normally recommend for men afterwards. It's done in the clinic again, under general anaesthetic as a day case. And I would normally say that men need at least 2 weeks off work after that. Some may take a bit longer to recover, but the surgery there is a bit more extensive.
Yes. And then I presume you'd preserve the sperm, you'd freeze the sperm, would you, in preparation for treatment at a later date? Is that?
Yeah, that's exactly right. Yeah, so the sperm are frozen, and in Bourne Hall, where we do the operation, it's right next to the embryology laboratory. So I'm passing samples across to the embryologists who are having a look, and they will then tell me whether there are sperm there or aren't, and if there aren't, I will continue to search. But if there are, then when we think we've got enough for treatment, we will, I will stop the dissection at that point, and can then, complete the surgery. So that close working relationship with the embryologists that we have at Bourne Hall, I think, is really important to minimize the amount of surgery that we need to do and to maximize the outcomes.
Yes, that's great. Thank you. We just got a few sort of more specific questions that are coming in. And one of them is about leukocytospermia, which I think is an infection in the urinary tract that can result in white blood cells or leukocytes in the ejaculate. And understand this has a negative impact on sperm function. Can you just explain a bit more about this? Can it be treated?
Sure. So it is something that we see, and it can indicate that there's a problem that comes from from the prostate, for instance, because of an infection in the prostate or an infection in the bladder, for instance. And so we would normally try and get a culture. So that means that we would send the sample off, and that would go into a microbiology laboratory, and they would try and see what exactly the bugs are.
Yes.
So that we know exactly what we're dealing with, and we can then target appropriate antibiotics. So often we would use an antibiotic that's very commonly used in patients who have inflammation or infection of the prostate. And we might give a 4-week treatment of that, and then check the semen analysis then a couple of months later. For some men or for some couples, having a sexual health screen to rule out some sexually transmitted diseases maybe as a cause of the leucospermia would be important. But it's not always possible to determine whether those white cells that you're looking at are infection-related cells, because sometimes they're what's called round cells, and they are kind of precursors of sperm, if you like. So it doesn't always necessarily mean there is an infection there, but we would certainly normally start by giving treatment for 4 weeks and then repeating the semen analysis a couple of months after that. Yeah,
that's great. And then another question, which is a general one. I mean, it sounds from what Matt says that Elle's full of life, but can male infertility have an impact on pregnancy or the health of the baby? Are there any concerns about that?
I would say that the process of, so certainly we know that as men get older, there is a very small increase in children who are born with disabilities, but it's on an incredibly low background. So although the increase depends upon your age and lots of other factors, it's on a really low background, and the same is true for ICSI. So because you're sort of bypassing some of the natural processes of fertilization, the rates of children who have problems is a little bit higher in patients who've had ICSI compared to those who've conceived naturally. Yes, that's great.
We've had quite a few questions about how to improve motility or morphology in general terms, but you were saying that with ICSI, you're actually selecting a really good sperm. So does ICSI overcome some of those issues?
So ICSI definitely does overcome some of those issues, but I think what we'd like to try and do is to make ICSI not the default position. So to kind of, to kind of come back to what Matt was talking about, which was to do with, how can you really improve the health of your own sperm? And I just wonder if I could just ask Matt whether or not, Matt, did you take any male fertility supplements or anything like that to try and improve your sperm count?
I think there was a Wellman one I was taking to start, and I took that for about 6 months along with everything else. And for me, I think the results were sort of negligible, so I stopped taking it. But yeah, no, that was a great sort of starting point for us when we got those results back. It was something else that we tried.
So I mean, I think that's important, because it's quite useful if men and couples can feel like they're able to do something themselves early on. And we talked about the lifestyle things, but I think taking a male fertility supplement so that maybe you don't have to get to ICSI is certainly something that couples should consider. And Matt said that he was on the Wellman fertility, and that's certainly one of them. There are several that you can buy which are specially formulated. They've got vitamins and they've also got antioxidants in there, and they are specially formulated for male fertility. So I would say that in any man where the semen parameters are below what we would expect, that's a very good place to start.
Yes.
Sorry, Oliver.
Yeah, sure.
Sorry, actually, I almost forgot there was a daily drink that I was drinking also, which was an orange powder. I can't remember the name of it now, but it was Proxseed.
Yeah.
Yes, Proxseed. Yeah, proxy was what I started taking after Wellman.
Okay.
Yeah, so proxy was the other
Yeah, that's
the other
right.
part. Yeah.
Yeah, so Proxeed is what I would ask a lot of my patients to take.
Yeah.
It's a sachet, like you say, you take it twice a day, and you know, there is some evidence that it can improve sperm count, but then also that if a couple is going through treatment, that actually maybe the sperm quality is better with it. So I think that's certainly worthwhile taking as well.
Yes, yes. And you, I mean, the various questions on those sorts of lines about improving your health. I mean, what about sort of like herbal remedies or anything like that, like maca root and walnuts and things, you know?
So what I would say is that you know, there are lots of things that are available, and I would only recommend treatment to my patient that I've seen good evidence, or as good evidence as we have, that it will help to improve their counts.
Yes.
So you know, there are companies that work in this space that have spent some time trying to formulate the correct you know, amounts of different vitamins and different antioxidants to try and improve sperm count, like you know, Matt was saying with Proxeed, or like Wellman. So for me, I recommend patients to take that. It's not for me a little bit of this and a little bit of that, and you know, see what happens, because it doesn't feel particularly scientific, and I
Yes.
don't think that there's always the evidence to support those.
Yes. Yeah. So yeah, so that's good. That's good advice. Yes. There are also some questions about the tests. I mean, it's increasingly possible to buy tests over the counter and do tests at home, but I presume the advantage of coming to an andrologist would be that you'd have the consultancy as well. You know, could you just explain perhaps the pros and cons of doing tests yourself?
Sure, I think it's a really good question. You know, I think that if you want to know, you know, if there are sperm in the ejaculate or not, then some of the over-the-counter tests that you can buy are you know, reasonable, but they're not particularly accurate from the point of view of telling you, you know, how many sperm are there, what are they moving like, what do they look like, and those are all really important things when considering a couple's fertility. So, you know, there might be a reasonable starting point, but clearly if you've been going, you know, a year, which is, you know, the point at which most medical professionals would say it looks like there's a problem with this couple's fertility, then I think that, you know, your GP is there, and that's what the health service is for. I would say, you know, get a proper test, get an examination as well, because there are underlying medical problems also that we haven't touched on, that can cause fertility issues. And you know, then you can be properly assessed as a couple. And it's kind of, you know, maybe a little bit, you know, easier just to buy an over-the-counter thing and not have to speak to anybody. But hopefully, you know, what Matt's been discussing tonight about, you know, being more open about things, and what we've seen a lot more in the media recently, will encourage men to say, look, you know, this is, you know, an illness or a problem, if you like, much like anything else. So, you know, go and speak to a GP. That's what they're for. Get the right tests done, have your hormones checked, and then, you know, you can see a specialist and hopefully improve your chances of having a family.
Yes. Yeah. It's just get good advice.
Do you think that's right, Matt?
Sorry, what was that?
Yeah, I mean, is that what you feel, Matt, listening to me? I mean, I'm, you know,
Yeah.
I'm talking from my point of view, but would you
No,
agree with that?
it's complete. I remember the drive to, because I had a test over in Cambridge, not at Bourne, for the initial test, and I remember that feeling of just going, oh, this is going to be so awkward. Everyone knows why you're there, and it's even from an embarrassment point of view. You know, you go to the clinic, you meet one person on reception, they direct you to where you need to go. There's a very discreet drop off. You don't see anyone. You're not handing anyone anything. Just so that from that point of view, it's don't ever feel that, you know, you're going into a waiting room with a small bag. It is very discreet. You press a bell, and you know it's all taken care of, and then you just leave. It's, you know, so yeah, completely.
Yeah.
And And in terms of getting advice, if somebody wanted to see you, Oliver, would they need to be referred to their GP, or could they book a consultation directly through Bourne Hall? How would they get to see
Yeah,
yourself?
sure. So if they live in an area where their CCG, which is the local group of GPs who buy services, where they've agreed that they will fund IVF or fertility treatment, then that is a way which they will see an andrologist first if there's a male factor problem. But unfortunately, not all CCGs or groups of GPs do fund fertility treatment at the moment. So if those couples or patients where there's a male factor wanted to come and see myself, then they would just contact the clinic at Bourne, and they would be booked in. And ideally, they would need to have evidence of their semen analyses so that we can have a sensible discussion, when we first meet, because, often for these men, these couples, it's been, 2 or 3 years when they've been trying and not getting any answers. And so, this is quite a big point whereby it's often the first time that the couple have seen a male fertility specialist. So me not being able to give them all the information that they want, I think it's not great from my point of view. It's definitely not great from the couple's point of view. So bringing all of the information that they've got from maybe other tests from GPs, and definitely the semen analyses is really important. But then also having those 2 hormone tests done at their GPs before, that's the FSH and the testosterone, and ideally it should be done in the morning.
Oh, right, yes.
Because the level of testosterone is highest in the morning, and then it comes a bit lower in the afternoon. So ideally, having all of that information at the first consultation will allow me or my colleague to, really give the best advice that we can and plan a way forward. Because I think, Matt, you can tell me that's what couples really want is a roadmap as to how the land ahead looks and what the journey is going to be like.
Yeah, because especially I think if you've been trying, I mean, myself and Laura were trying for about a year and a half before we actually spoke to somebody, and I think it's almost like that anchor to hold on to. If you've got a direction, you've got a plan, you can see your way through the storm without sounding too dramatic. So yeah, it's important to sort of keep all your ducks in a row.
Well, that's really great. Well, thank you both of you. That's been really brilliant. I think sadly that's all we've got time for at the moment. We've got through quite a lot of the questions. I mean, there are quite a few sort of specific ones that we haven't managed to cover. But I hope that when people perhaps have an opportunity to go back through the videos and perhaps listen again to the webinar, they'll find that some of their questions were perhaps answered earlier on. So I would just like to say thank you very much to our guests, Matt and Oliver, and also to yourselves for participating. If there are any issues, particularly some of the things that Matt was saying that this discussion has raised that you'd like to talk through, we've actually got a fertility support group meeting next week on Thursday the 18th, and that's quite a good opportunity to sort of talk about perhaps more of the fertility journey and the impact that's having on yourselves and your relationships. So it just leaves me to say that whatever stage you are on your fertility journey, I hope that this session has been helpful, and we wish you every success going forward. So have a very good evening and goodbye. Thank you.